Dr. Madan Gopal, who is a senior consultant health at NITI Aayog, to talk about how you are looking at what are the steps needed for accelerating citizen services delivery through e-governance.
Thank you, Raviji. Thanks for this question. If you look at the finance, our Honorable Finance Minister's speech, she has mentioned about Sankalp Siddhi in the Amrit Kal. And if you look at the digital health, we are having the Sankalp in the form of National Health Policy 2017. We have made the National Digital Blueprint, which talks about the federated architecture for digital health in the country, and some of the elements have been rolled out as a National Digital Mission. The story doesn't stop here, as Tripathi ji has pointed out. So we have to see that how the rainforest approach is consolidated, and we at least make citizen-centric things. Name a problem in the health sector, you are having an app for that. And so many apps are there, we don't know which apps to use. If you talk about, we have to make technology which is very simple to use, easy to accept and adopt, like WhatsApp, like UPI interfaces. You have to see that how the technology, it should be teaching us. When the Uber and Uberization, this Ola people came, the radio-based cab came, the drivers, most of them, they don't know English, but they know how to operate the Google Map. Now they are very expert in that, they have innovated. And look at the UPI interface, how it has revolutionized. Even the people who are there. Now you see how innovations have happened. The receiver and the people who are making payment. This kind of applications we have to see how it can be used. During the COVID times, we have tried to experiment with the Arogya Setu app. There were a lot of problems, though it was made into that. But the actual objective of the Arogya Setu was very beautiful, because if we, being an epidemiologist, I know the importance of contact tracing, and after doing the contact tracing, identifying the person and putting that person into quarantine or isolation, that's a very important aspect. It was meant to do that thing, because when during the first wave, when we were not knowing what is the treatment modality, so we required some time. So one of the aspects as an epidemic protocol, it's a quarantine is the very standard measures, and we have been doing it. That's the basics of epidemiology. And Arogya Setu was one of the tools which was there. But looking at the way things have evolved, so the purpose, initially the cases were less, it has acted beautifully. The moment the number came, then things started, it became very difficult. The other enablement for the citizens was the telemedicine and the telemedicine guideline. Before 20, teleconsultation, telemedicines were not that legal. And after the telemedicine guidelines were released, telemedicine practice guidelines were released, then you see during the second wave, when the health system was overwhelmed for 2-3 weeks, is the telemedicine guidelines along with the digital tools, in the form of digital thermometer as well as the pulse oximeter, and aided by the telemedicine guidelines, and we know that 80% of the patients can be managed at the home. Though the system was overwhelmed for 2-3 weeks, but we could manage the second wave, which very nicely. Third important aspect, we have been talking about the CoWIN platform, which has become a public good, and we have been now sharing with the international community as well. But we were having the previous version of that EVIN, which we were using for the logistics management of the vaccination program. That infrastructure was there. As Tripathi ji has mentioned, that a lot of journey is happening. That has happened. So going forward, we do have a national digital mission. In the previous session, they have talked about a lot of programs, a lot of data is being collected. But many portals, they are collecting data. Suppose I am accessing services of malaria, so my data is collected. For TB, data is collected. For immunization, data is collected. But the data systems don't talk to each other. That's why the seeding of these records with the ABA ID becomes very important. We have been able to at least identify around 30 crore ABA IDs, but the biggest challenge lies in seeding this ABA IDs into this record so that some meaningful, even if you want to use machine learnings or run some AI algorithms, these data sets are required. The another important aspect when we want to make citizen-centric thing, we have to make the interface, user interface very simple, easy to understand, so that the adaptation becomes very easy. As WhatsApp and other things they have done, it becomes very easy. You just introduce that person and he will learn everything. You have to make technology and other things such simple that easy adaptation and easy capacity building can also happen. So we are moving in that direction, and let's hope that things happen.
Taking a cue from here, the gap between technology innovations and the user departments. You represent the health sector. So if you like talk about that, how is that gap increasing or decreasing in the health sector, and how is the e-governance as a sector can evolve by collaboration between the technology and the user departments?
It's a very difficult and very tricky question to answer because as Sir has pointed out, that means we have to, in the initial remarks also I mentioned that we have to make a user interface which is acceptable by the people. What is happening, because we are having HMI system in the health system, and it is, over the years it has evolved. And what we are doing, we are trying to have a high-end kind of operations, high-end data to be collected by a person who is not that educated, not that exposed to technology. And we are expecting all the things to be done by that person. As a result, what is happening, 40% of our ASHA and the A&M work time is going to the data collection only. That can be used for some other useful and other activities, which is not happening. The second thing is, everybody wants to have their own data sets. That's the biggest thing. They don't want to use the data collected by the system for some other purpose. They want to have their own data sets. COVID is also an example. We were having 3 portals, 3 different data coming, and they were not talking to each other. And that came the role of our organization. That means how to facilitate all this thing, because it was interministerial. That's one thing. It is getting complex and complex because healthcare delivery is getting complex and complex. We have to find solution. You see that how we repurpose or re-engineer the things to have an effective way. If you look at the way things have progressed, technology is not only digital. If we talk about the approach for the delivery of the services, we have adopted the primary healthcare approach for reaching the health for all objectives and now the Millennium Development Goals and the SDGs. The approach has been changed. The strategy has been changed from primary healthcare approach to a comprehensive primary healthcare approach. We have to provide accessible, affordable and acceptable healthcare by use of locally available technologies and other things. That was the overarching guiding principle for that. And we have to find solutions for that. If the local technologies are to be used, then only you can succeed in that. You take the examples of the AIM software. Without the practitioner's interface, the software was rolled out. And it took a lot of time to address that issue of appointment and other systems. We should not be landing up, because the moment we are using it, in the initial remarks also I mentioned that you identify a problem in the health and you will have a good app and others. And we are struggling. Everybody is coming and making presentation. This is a good solution which is there. As if nothing is happening in the health system. It's not like that. Over the last many years, we have been able to reach right up to 3,000, 5,000 population where we are having a health institution. Previously, we used to call that health institution as a sub-health center. Now, that has been upgraded to provide comprehensive care, and we call it as a health and wellness center. So, the reach is there. Every village, the extension services happens through the health workers, and the health workers are assisted by the ASHA workers. That's the structure. It's not that simple. And if you look at the public health structure, so you have the presence in each and every village. And that's why during the COVID time, the system has shown its resilience, be it the contact, be it reaching to the masses, doing a rapid survey, that has happened. And if you look at the newspapers and the media articles when the vaccination program was rolled out, how they were, all the people were skeptical. The people who are sitting and the technology driven people, they were skeptical that India kar nahi sakta hai. But you see, we did it because we had the know-how, we had the capacity. One of the important things which Sir has also mentioned is the skilling and capacities of the people. Even if you make a good solution, where is the capacity? We have to see that how the capacities, the technology itself add to the capacity of the person. We have to make the technology as simple as that. So that it teaches the person how to use it, how to improvise on that and take the things forward. And lot of things have been happening. I've been looking at, since 2002, we have piloted some tab-based HMI system for the A&M. At that time, Asha was not there. We have experimented that. We have experimented with source the slate and other things. But something is missing. The moment it comes from pilot to scaling, things fizzle out. We have to find out and address that kind of issues. If it is accepted by the people, it is making the lives of the people, definitely they are going to adopt it. So I'm just citing before I close, when I was working in one of the very challenging states in the country, at that time, way back in 2002, 2003, we have supplied computers to the block level. And people were saying that why you are giving computers? We thought that at least let them play games. At least they will get familiarized with how a computer looks like. And after seeing that they need not to repeatedly try it, they started using it as a word processing, as a typewriter they started using it. The moment the block accounts officer, he thought, he understood the value of making the Excel sheets and seeing the utility of that, now it's a history there. So it's not that you have to make whatever technology we are taking to the people, you have to see that they have been acceptable to them and see that how they use it. So for their benefit.